Welcome back to the Deep Dive. Today we are cutting straight to the chase. If you are listening to this, you are likely staring down the barrel of a major exam, the plastic surgery boards, the FRCS, or, a similar high-stakes milestone. You don't need fluff, you need high-yield facts, and you need to know how to deliver them under pressure.
That's right. We are treating this session as a simulation. I'm ready to be grilled.
Good, because today we are tackling the heavy hitter, squamous cell carcinoma of the head and neck. We are going to tear apart the staging nuances, dissect the neck levels, literally and figuratively, and walk through those crisis management algorithms that examiners love.
Yeah, the ones that used to trip you up. This is the bread and butter of the specialty. You cannot pass if you are weak on this.
Exactly. Before we dive in, a quick bit of housekeeping. If this rapid-fire revision style helps you, rate the show. It really helps us get this material to other residents who are probably panicking right now. Also, leave a comment on what topic you want next. We build this schedule based on what you need.
And I have to be blunt here. This deep dive covers the what. It's the facts. But if you want the how and the why, you need the full picture. You need to subscribe to the premium feed. That is where we keep the journal club breakdowns and the detailed clinical cases episodes.
Seriously, do not walk into the Viva without listening to those cases. They bridge the gap between textbook knowledge and, consultant-level decision-making.
Yeah.
All right, preamble over. Let's get to work. Pathology.
Hit me.
We are talking squamous cell carcinoma. Basic science first. Where does it actually come from?
It arises from the lining membranes of the upper aerodigestive tract.
Simple enough. But in an exam, I'm going to show you a slide, and I'm going to ask for a differential. SCC is the headline act, but who are the supporting characters? Give me 5 other mucosal malignancies.
Okay, rapid fire. You have adenocarcinoma. You have sinonasal undifferentiated carcinoma, usually just called SNUC.
SNUC, right.
Olfactory neuroblastoma. You have malignant melanoma, which can occur on these mucosal surfaces. And finally, lymphoma.
Excellent. That's the list. Now let's get into the weeds of staging. The T classification. We all know the basics. TX means we can't assess it. T0 is no evidence. TIS is in situ. I want to zoom in on T4. This is where the pass-fail line often sits. Yeah. For all sites except the nasopharynx, how do we split T4?
We split it into T4A and T4B, and this distinction is critical because it basically dictates operability.
Okay, so T4A is what?
T4A is defined as moderately advanced local disease. T4B is very advanced local disease.
Translate that into surgical reality. What does T4B actually mean for the patient?
T4B usually implies invasion of really critical structures like the skull base, the internal carotid artery, the prevertebral fascia.
So it's a big deal.
It is. In most centers, T4B is considered unresectable. T4A, on the other hand, is generally resectable.
So T4A is go, T4B is stop, generally speaking. Let's look at the maxillary sinus. There is a specific anatomical line here that examiners love because it combines history with prognosis. What is it?
That would be Ongren's line.
Visualize it for the listener who's maybe driving their car right now. Where do I draw it?
You take a marker and draw a line from the medial canthus of the eye, so the inner corner diagonally, down to the angle of the mandible.
And why does a line drawn in, 1933 still matter today?
Because it divides the maxillary sinus into 2 prognostic zones. If the tumor is antero-inferior to that line, so below and forward, it generally has a good prognosis.
And postero-superior.
If it is postero-superior above and backward, it has a poor prognosis.
Why? Is the tumor biology different?
No, it's purely anatomical real estate. Postero-superior tumors are sitting right next to the orbit and the skull base. Clearance is harder, and the risk of critical invasion is just much higher.
Perfect. Let's move down the neck. Nodal staging, the N classification. This system is fairly universal for most head and neck tumors, but there is one massive exception. We'll get to that. First, lay down the standard rules. What is an N1 neck?
N1 is a single ipsilateral lymph node, and it must be less than or equal to 3 centimeters in greatest dimension.
Okay. N2. This is where people get mixed up. Break it down for me.
So N2 is the middle ground, divided into A, B, and C. N2A is still a single ipsilateral node, but it's bigger, so between 3 and 6 centimeters.
N2B.
N2B is multiple nodes, but they are all ipsilateral, and none of them are greater than 6 centimeters.
And N2C.
This is the crossover. N2C is bilateral or contralateral lymph nodes, none greater than 6 centimeters.
And N3 is easy.
N3 is any lymph node greater than 6 centimeters.
Here's a specific trap. I have a patient with a node right in the midline. Is it contralateral? Is it its own category?
No. Midline nodes are considered ipsilateral for staging purposes.
Good, don't fall for that one. Now, the exception you mentioned. Which cancer refuses to follow these rules?
Nasopharyngeal carcinoma. The staging and prognosis are completely distinct from the rest of the head and neck.
This is crucial because if you apply the oral cavity rules to a nasopharynx case, you will fail the station. So walk me through the nasopharynx end staging.
Right. For nasopharynx, N1 is a unilateral node, less than or equal to 6 centimeters, but it must be above the supraclavicular fossa. It can also include retropharyngeal nodes.
So the size cutoff jumps to 6 centimeters immediately.
Correct. And N2 is bilateral nodes, less than or equal to 6 centimeters, again, above the supraclavicular fossa.
And N3.
N3 is split. It's based on location and size. N3A is any node greater than 6 centimeters. N3B is extension into the supraclavicular fossa.
Be precise. In this context, what is the supraclavicular fossa?
We define it as a triangular region, including the caudal portions of levels IV and B.
Okay, you brought up levels. Let's do the anatomy. This is hard to visualize on audio, so I want you to paint a picture. Level I, what are we talking about?
Think of level I as the floor of the mouth and the chin. It's divided into IA and IB. IA is the submental triangle right under the chin between the anterior bellies of the digastric muscles.
And IB.
IB is the submandibular triangle that sort of side sweep under the jaw.
What's the key content of IB?
The submandibular gland, and the surgical note here is that the gland itself is included in the excision specimen for level IB.
Level 2, the upper jugular.
Okay, so imagine the area from the skull base down to the hyoid bone. That's the vertical span.
And it's split into A and B. What divides them?
The spinal accessory nerve, the sana IIA, is anterior to the nerve. IIB is posterior. This matters because digging around in IIB puts the nerve at a much higher risk.
Makes sense. Level 3, mid-jugular.
We are moving down from the hyoid bone down to the cricoid cartilage. It sits between the sternohyoid muscle and the posterior border of the SCM.
Level 4, lower jugular.
From the cricoid cartilage down to the clavicle.
Pause here. Level 4 is the danger zone for the junior resident. Why?
Because the anatomy gets tight and you have the lymphatic ducts. On the left, you have the thoracic duct. On the right lymphatic duct. Damaging these causes a chyle leak.
And Virchow's node.
Exactly. Virchow's node implications for distant Mets.
Correct. Level V, the posterior triangle.
This is the area behind the SCM in front of the trapezius and above the clavicle. It's divided by a line from the inferior border of the cricoid. VA is above that line, the spinal accessory nodes. VB is below so, transverse cervical and supraclavicular nodes.
Level 6.
This is the anterior central compartment. Think thyroid. It's between the carotid arteries from the hyoid to the suprasternal notch. It holds the pre- and paratracheal nodes, parathyroidal nodes, and the Delphian node.
And finally, level 7.
The upper mediastinum. It's really the extension of that paratracheal chain down to the innominate artery.
Okay, you know the map. Now let's talk about the mission. Neck dissections. 3 main categories. Start with the historic gold standard, the radical neck dissection, or RND.
An RND is the take-everything approach. You remove lymph nodes from levels I through V. But crucially, you also sacrifice 3 non-lymphatic structures: the spinal accessory nerve, the internal jugular vein, and the sternocleidomastoid muscle.
We rarely do this now. So what is the workhorse procedure today?
The modified radical neck dissection, or MRND. It removes the same nodal packet levels I through V, but you preserve 1 or more of those 3 non-lymphatic structures.
You have to specify which ones you save, right? You can't just write MRND.
Exactly. You have to specify. You might see MRND type I, which preserves the nerve, but in practice, you usually just write it out. MRND with preservation of the SAN and IJV.
Then we have the selective neck dissection, the precision tool.
Exactly. Here we preserve specific lymph node levels based on the predictable drainage patterns of the primary tumor. We are basically betting that the cancer follows the rules.
Let's test that bet. I'm giving you a primary site. You tell me the procedure. Scenario 1, oral cavity cancer.
The drainage is primarily to the upper neck. You do a selective neck dissection of levels 1, 2, and 3.
What if it's a deeply invasive tongue cancer?
Then the skip metastasis phenomenon comes into play. You should extend that to include level 4.
And a midline tumor.
Then you are committed to a bilateral SND, levels I through 3, sometimes 4.
Scenario 2, oropharyngeal or hypopharyngeal cancer.
The drainage shifts posteriorly, so you do an SND of levels 2, 3, and 4. You don't usually need level 1.
Scenario 3, midline structures of the anterior lower neck. A larynx or thyroid carcinoma.
That's a level 6 eye dissection, the central compartment.
Scenario 4, cutaneous malignancies, a nasty SCC on the posterior scalp.
So the drainage is backward and downward. You need levels 2 through V, but you also need to get the suboccipital and postauricular nodes.
Okay, let's talk philosophy. Management decisions. We have the N0 neck clinically negative. The scan looks clean, palpation is normal. Why are we cutting into this neck?
Because we don't trust it. The rate of occult microscopic disease, the stuff we can't see on scans, is high. For oral cavity tumors, the risk is over 20%. For oropharynx and hypopharynx, it can be over 50%.
So it's a statistical gamble.
It's a calculated strike. If you observe an N0 neck and it relapses later, the salvage rates are terrible. Plus, a selective neck dissection on an N0 neck gives you the same control rate as a radical neck with much less morbidity.
Now, the N+ neck, clinically positive.
That changes the game. You need active treatment. Surgery, chemo, radio, or, all three. For N+ necks, generally, a modified radical dissection is the standard to ensure control.
What if it's N2 or N3? Big, bulky disease.
That is usually a multimodality fight. There is evidence that doing an MRND after chemoradiotherapy confers a survival advantage in these advanced cases.
Let's shift gears. We are in the OR. Things are going wrong. I want to talk about crisis management. Examiners love this.
Understood.
Disaster number 1, air embolus. You have an open vein, maybe the IJV is torn, you hear a churning murmur, the pressure crashes. What is your immediate reflex?
Don't think, just act. Step 1, pack or ligate the vein to stop more air getting in. Step 2, the Durant maneuver, turn the patient onto their left side with the head down.
Why specifically the left side?
It traps the air bubble in the right atrium and keeps it away from the pulmonary artery outflow tract. It buys you time.
And if they arrest?
You are aspirating via a central line directly from the heart.
Disaster number 2, the exam standard. You are dissecting level 2 and you hit the internal jugular vein, massive hemorrhage. The field is flooded. Walk me through the algorithm. Do not skip a step.
Okay. Step 1 is communication. Tell the anesthetist immediately they need to manage fluids and pressors.
Step 2.
Control. Finger pressure. Stop the bleeding. Stop the air embolus risk. Take a breath.
It's still bleeding when you lift your finger.
Step 3 is exposure. Use 2 suctions if you have them. Dissect the tissues around the injury to isolate the hole. If it's repairable, you suture it.
The vessel is like wet tissue paper. The suture tears through.
Then you plug it. If a finger or gauze fails, you use a muscle plug. Take a segment of the SCM and suture it over the defect.
It's catastrophic. The muscle plug isn't working. It's an uncontrollable tear extending downwards.
You call a thoracic surgeon. You're going to need to crack the chest to control the vessel in the superior mediastinum.
What about the other direction? The tear is high, near the skull base. The stump retracts into the jugular foramen. You can't clamp bone.
You can't clamp, so you pack. Use a hemostatic agent like Surgicel. Pack it firmly into the jugular foramen. Then, to keep it there, you take the posterior belly of a digastric muscle and plicate it, stitch it over the hole, a biological cork.
Perfect. That sequence is the pass-fail key. Now, post-op. You check the drain on day 2. It's milky.
Chylus fistula, likely a thoracic duct injury in level 4.
Management.
Start conservative. Put the patient on a fat-free diet with medium-chain triglycerides. This reduces chyle production. If the leak is high volume, stop oral intake, start TPN.
And the nightmare vascular complication on the ward.
Carotid blowout, often fatal. It's usually seen in patients with a salivary fistula or previous heavy radiation.
It rarely just bursts without warning. What is the sign?
The sentinel bleed, a small self-limiting bleed from the neck or mouth. If you see this, you do not wait. It mandates immediate surgical exploration.
And the fix. You can't just stitch a radiated carotid.
No, it will tear. You need healthy coverage. You have to bring in vascularized tissue, a pedicled pec major flap, or a free flap to cover and protect the artery.
Well, let's move to a diagnostic mystery. The unknown primary.
This is defined as SCC in a neck node, usually level 2 out of 3, where we cannot find the source despite a full workup. It's rare, less than 5% of cases.
Walk me through the detective work. Step 1.
History and exam. But really, look, palpate the tonsils. Look at the tongue base.
Step 2. The node is right there. Do we cut it out?
Absolutely not. No open biopsy. You risk tumor spillage. You do an ultrasound-guided core biopsy. We prefer core over FNA because we need architecture and markers.
What markers specifically?
We check for EBV Epstein-Barr virus, which points to the nasopharynx, and we check for HPV-16, which points to the oropharynx.
Biopsy confirms SCC. Step 3.
Imaging. PTCT is the gold standard here. It lights up the primary in about a third of cases. You also need a CT from skull base to diaphragm.
The scan is negative.
Step 4.
Canondoscopy under anesthesia. You look at everything, nasopharynx, larynx,
Mm.
esophagus. You take deep biopsies of anything that looks even slightly asymmetrical.
Everything looks normal.
So you do blind biopsies of the likely hiding spots, the base of tongue and the nasopharynx.
Still nothing. We are running out of options. What is the final diagnostic maneuver? Ipsilateral or bilateral tonsillectomy. The primary is often a microscopic focus hidden deep in a tonsillar crypt. The combination of PTCT and tonsillectomy gives us the highest yield.
And if we still don't find it,
We stop hunting and start treating. We treat the neck with a dissection, usually MRND or SND, and then we use total mucosal irradiation. We radiate the likely primary sites and the neck.
speaking of radiation, let's wrap up with adjuvant therapies. You've done the surgery. Who needs radiotherapy?
Patients with high-risk features, T3 or T4 tumors, close or positive margins, perineural invasion, and the big one, extracapsular spread or ECS in the lymph nodes.
And chemo.
Usually platinum-based, like cisplatin. It's added for those very high-risk features, particularly positive margins or ECS.
One final drug, cetuximab.
It's a monoclonal antibody against EGFR. It's useful, conferring a survival advantage in advanced T3, T4 lesions compared to radiotherapy alone.
All right, that was a marathon. Let's distill this. Give me the top 3 things the listener needs to memorize before they walk into the exam hall.
1. The anatomy is not negotiable. You must be able to describe the boundaries of levels I through V fluently. If you stumble on where does level 3 end, you look unsafe.
2.
The bleeding algorithm. IGV injury is the classic crisis question. Memorize the escalation ladder. Pressure, exposure, repair, muscle plug, digastric plication.
And 3.
The unknown primary rule. Never, ever do an open biopsy as your first step. Follow the algorithm. Core biopsy, PETCT, penendoscopy, tonsillectomy.
Fantastic. Listeners, we have covered the ground, but to truly own this material, you need to see it applied. The clinical cases episodes on our premium subscription take these facts and put them into real-world scenarios.
Absolutely. Complicated patients, comorbidities, difficult decisions, that is where the high scores come from. The difference between a pass and a merit is in the application of knowledge, not just the recall.
So get the subscription, rate the show so we can keep doing this, leave a comment with the next topic you need us to break down. Good luck with the revision.
Good luck. Go crush it.